welcome in. I'm really glad you're joining us today for this.
Yeah, thanks for having me. It's a great topic we've got lined up.
It is. And, if you're listening to this, you're likely a medical student prepping for your forensic medicine exams, or maybe a junior doctor trying to navigate those tricky medical legal responsibilities on the ward.
Or even a senior clinician, just taking some time to revisit the foundational tenets of the field.
Exactly. Whoever you are and wherever you are in your medical training, we've got a really highly structured, clinically focused, deep dive plan for you today.
We do. And our mission is pretty clear.
Right. We are unpacking the principles laid out in Chapter 4 of Simpson's Forensic Medicine.
Which focuses on violence in society, the medical legal investigation of death, and the autopsy.
Yeah. And the byline for today's session is simple but vital. From scene to scalpel, truth unfolds layer by layer.
That concept of layers is so fundamental to everything we'll discuss today, because we're moving far beyond just, rape memorization.
Right. Memorizing a list of injury types or legal statutes might help you scrape by on a multiple choice paper.
But it won't help you when you're actually standing in the mortuary trying to interpret a complex pattern of trauma, or when you're on the witness stand explaining your findings to a jury.
I mean, that's where the real pressure is.
Exactly. So our goal here is to build a robust conceptual framework. We really want to understand the continuum of violence.
Which starts with a mechanism of injury.
Yes. Mechanism of injury, which produces the physical pathology, which then requires your objective clinical interpretation and ultimately culminates in a legal implication.
And the core principle that you really must anchor yourself to is this: the medical legal investigation doesn't magically begin when a body is wheeled into the mortuary.
No, it begins out in the world, at the scene.
Okay, let's unpack this.
Yeah.
Because before we even get to the specific scene of an incident, we have to look at the macro level. We need to understand the epidemiology of violence.
Right. And the text opens by positioning interpersonal violence not just as a matter of criminal justice, but as a massive international public health concern.
Yeah, it leans heavily on the United Nations Global Study on Homicide data from 2013 to establish a baseline. And those baseline numbers are sobering, to say the least.
You really are.
In 2012 alone, there were roughly 437,000 homicides globally.
Which averages out to 6.2 intentional homicides for every 100,000 people on the planet.
It's a staggering figure.
Yeah.
But what's crucial for a clinician to understand is how those numbers fracture when you look at regional extremes.
Yeah, you have that global average of 6.2, but the geographic distribution is wildly uneven.
Right.
In Central America, at the time of that study, you see rates soaring to just over 25 per 100,000 people. In Southern Africa, it pushes past 30 per 100,000.
I think the TAP mentioned Honduras specifically.
It did. Honduras was reporting an astronomical rate of 90.4 per 100,000.
Wow. And then you contrast that with Western Europe, which hovers around 1 per 100,000.
Yeah, and Japan is even lower at 0.3 per 100,000.
So where does the UK sit in all this?
The UK specifically reported a rate of exactly 1 per 100,000. There are some minor regional variations. England and Wales at 1.1, Scotland slightly higher at 1.74, and Northern Ireland at 1.42.
And just for comparison, the United States sat at 4.7.
Right.
So let me ask you this. If I'm a pathologist or a forensic physician working in a mortuary in London versus working in Johannesburg or Baltimore, how exactly does this macro-level public health data change my day-to-day clinical practice?
That's the key question.
Right, because why do I need to know the UN homicide rate when I literally have a specific patient or a body in front of me?
Because it establishes your clinical baseline, what we might call your pre-test probability.
Pre-test probability, like assessing cardiac risk based on age and lifestyle.
Exactly like that. Understanding the demographic and geographic context helps you anticipate specific injury patterns and recognize systemic vulnerabilities. It bridges the gap between abstract public health data and the individual pathology you're examining.
Makes sense.
If you're practicing in an area with a homicide rate of 90 per 100,000, your threshold for suspecting unnatural death in an ambiguous case is naturally going to be calibrated differently than if you're practicing in rural Japan.
Right. The data informs your clinical vigilance.
Yes, it sets your baseline awareness.
Well, let's talk about the specific demographics within that data, because violence is certainly not distributed equally across populations.
Not at all. Globally, 79% of all homicide victims are male, and a massive 95% of all perpetrators are male.
And we're also looking at a predominantly young demographic, aren't we?
We are. Most victims are under 44 years old, with 43% falling into that 15 to 29-year-old bracket.
There's also that really grim reality mentioned in the text that 8% of victims globally, which is about 36,000 deaths, were children under 15.
Yeah. And in England and Wales, the highest rate of homicide was actually in children under 1 year of age, most often killed by a parent or step-parent.
It's awful.
Yeah.
But then when we shift our focus to intimate partner violence, the demographic risk profile just inverts entirely.
It does. Globally, almost half, 47% of all female homicide victims are killed by an intimate partner or family member.
47%. And for male victims?
For male victims, that number is only 6%.
That is a vital distinction for the forensic practitioner to hold on to.
It really is. Because when a female victim presents, particularly from a domestic setting, the statistical probability that the perpetrator is someone within her immediate circle is incredibly high.
So this directly guides how the police will investigate the scene.
Yes, and it guides how the pathologist will interpret the injuries, keeping in mind the typical mechanisms of domestic assault.
Speaking of mechanisms, the actual weapons or methods used vary drastically depending on where you are.
They do. Firearms dominate the Americas, accounting for about 66% of homicides.
But if you're practicing in the UK, the landscape is totally different.
Right. Because of strict firearm legislation there, sharp objects, knives, broken bottles, screwdrivers, they are the primary mechanism. They account for roughly 35 to 38% of deaths.
Which means a UK pathologist is going to become highly specialized in interpreting sharp force trauma.
Precisely. They need to differentiate between an incised wound and a stab wound.
And what's the clinical difference there, just to clarify for everyone?
An incised wound is longer on the skin surface than it is deep. A slash, basically. A stab wound is deeper into the body than it is long on the skin.
Okay, got it.
They also have to learn to look at the margins of a stab wound to determine if a single-edged kitchen knife or a double-edged dagger was used, or to look for hilt marks bruising the skin.
Hilt marks.
Yeah, which indicates the blade was driven into the hilt with significant force. The handle literally bruises the skin.
Right. Whereas a pathologist in the United States, conversely, will see a much higher volume of ballistic trauma.
Yeah, requiring expertise in interpreting entrance versus exit wounds, stippling from unburned gunpowder, and the internal cavitation caused by high-velocity projectiles.
So the society really dictates the pathology.
It absolutely does.
Within that UK data on intimate partner violence, I noticed there's a stark gender difference in the mechanism of injury as well.
There is. Male victims of partner homicide are predominantly killed with sharp instruments, about 60%.
But female victims of partner homicide are significantly more likely to be killed by strangulation or asphyxiation compared to other female homicide victims.
Right. We're looking at 27% versus 16%.
So what exactly does a pathologist look for to confirm strangulation? I mean, what's the mechanism there?
So strangulation is a highly specific mechanism. Asphyxia, in this context, isn't usually about crushing the airway so the person can't breathe.
Oh, really? I think most people assume it's about crushing the windpipe.
It can happen, but it's primarily about compressing the blood vessels in the neck. The jugular veins, which carry blood away from the head, are superficial and easy to compress.
Okay.
The carotid arteries, which carry oxygenated blood to the brain, are deeper and require more pressure to occlude.
So what happens when pressure is applied?
If a perpetrator applies enough pressure to block the jugular veins but not the carotid arteries, blood continues to pump into the head but cannot drain out.
Oh, wow. So the pressure just builds up.
Exactly. The venous pressure in the head builds rapidly until the tiny capillaries in the eyes, eyelids, and face literally burst under the pressure. These pinpoint hemorrhages are called petechiae.
Right, petechia. So if a clinician sees those petechial hemorrhages, that is an immediate red flag for compression of the neck.
Absolutely. It's a classic sign.
Oh.
The pathologist will also perform a very delicate, bloodless dissection of the neck to look for deep bruising in the strap muscles.
And what about the bones in the neck?
Yes, they'll meticulously examine the hyoid bone, which is a small U-shaped bone high in the neck, and the thyroid cartilage for fractures.
I've heard the hyoid bone mentioned a lot in forensics.
Right. In young people, the hyoid is quite flexible, but as we age, it calcifies and becomes brittle, making it more prone to fracture during manual strangulation.
So knowing that women in domestic settings are statistically at higher risk for this specific mechanism means the pathologist approaches the autopsy with a heightened vigilance for these really subtle signs.
Exactly. You know what you're statistically likely to find, so you look closer.
That brings us to the socioeconomic and racial inequalities discussed in the text. Violence is clearly not an equal opportunity killer.
No, it's not. In the United States, the age-adjusted homicide rate for white males was 8.7 per 100,000, but for black males, it was 66.2 per 100,000.
And in England and Wales, black males are 4 times more likely to be victims of homicide than white males.
And socioeconomic deprivation plays a massive role globally, too.
Yeah, the data from Scotland highlights this perfectly. Between 2000 and 2002, a man under 65 living in one of Scotland's most deprived areas was nearly 32 times more likely to die from assault than a man in an affluent area.
And for women, it was 35 times more likely.
Those statistics are sobering.
They are. And they reinforce why forensic medicine cannot exist in a vacuum. The pathologist is dealing with the end result of profound social failures. The injuries on the autopsy table are the physical manifestation of those statistics.
But once that violence has occurred and a death has taken place, the abstract statistics fade away, don't they?
Yes, a very specific legal machinery takes over. The medical framework must interface with the state's legal framework.
Let's transition into that medical legal framework then. For a junior doctor working on the wards, the vast majority of patient deaths they deal with will be natural.
Right.
When a patient dies of an expected natural cause, say terminal cancer or a documented myocardial infarction, the attending doctor signs a medical certificate of cause of death, an MCCD.
Which is a straightforward administrative act that allows the family to proceed with registering the death and organizing a burial or cremation.
But what happens when the death falls outside those neat boundaries?
When a death is unnatural, suspicious, or simply unexplained, the attending doctor cannot legally sign an MCCD. They must refer the death to the coroner.
How common is that referral?
Well, in England and Wales, out of roughly 500,000 deaths a year, about 220,600 are reported to coroners.
Almost half.
Yeah. And of those, roughly 85,600 require a post-mortem examination to establish the cause.
I want to clarify something about those numbers. Because the text mentions a significant historical shift in the UK involving something called Dole's, the deprivation of liberty safeguards.
Oh, yes.
What exactly was this, and how did it impact the forensic system?
This is a perfect example of how healthcare legislation directly impacts the medical legal workflow. Dole's was an amendment to the Mental Capacity Act of 2005.
Okay.
It was designed with the best of intentions to protect vulnerable people like elderly patients with advanced dementia or severe learning disabilities who lack the cognitive capacity to consent to their care arrangements.
To make sure they weren't arbitrarily locked in care homes or hospitals without oversight.
Exactly. It ensured proper legal checks were in place.
That sounds like a really necessary clinical safeguard. Where does the coroner come in?
The issue arose with how the law classified these patients. Under the original framework, a patient living under a Dole's authorization was technically considered to be in state detention.
Wait, state detention? Like a prisoner?
Yes, legally speaking. Now, under coronial law, any death that occurs in state detention, like a prisoner dying in a jail cell, must be reported to the coroner and requires a mandatory inquest, often with a jury.
Oh, I see where this is going.
So suddenly, coroners were being inundated with thousands of reports of elderly patients dying peacefully in their sleep from advanced Alzheimer's disease in care homes simply because they had a Dole's authorization in place.
That sounds like a massive administrative nightmare.
It was. It placed an immense, unnecessary bureaucratic burden on the coronial system. And worse, it distressed families who were subjected to mandatory inquests for entirely natural deaths.
So how was it resolved?
In 2017, the law was amended so that a Dole's authorization no longer automatically equated to state detention for the purposes of coronial reporting.
Makes sense.
Almost overnight, the number of Dole's deaths reported to coroners plummeted by 66%. It allowed the system to refocus its resources on genuinely suspicious or unnatural deaths.
That context is incredibly helpful for a junior doctor trying to understand the paperwork they are dealing with. Aside from state detention, what are the specific criteria that mandate a doctor must refer a death to the coroner?
The criteria are broad to ensure nothing slips through the cracks. A doctor must report a death if there is no attending practitioner available to sign the MCCD, or if the doctor hasn't seen the patient within a specified time frame prior to death.
Which makes sense. What about trauma?
Crucially, they must report any death where there is suspicion of violence or trauma. They must report poisonings, cases of intentional self-harm, or deaths resulting from neglect or a failure of care.
What about surgical deaths?
Yes, they must report deaths related to medical or surgical procedures. For instance, if a patient dies unexpectedly on the operating table. They must also report employment-related deaths, like industrial diseases such as mesothelioma from asbestos exposure. And of course, they must report any death where the cause is simply unknown.
Let's explore a clinical scenario to really lock this in.
Okay.
An 85-year-old woman trips on a loose rug in her home and fractures her neck of femur. She's admitted to the hospital, has surgery to repair the hip, but due to her prolonged immobility in the hospital bed, she develops a deep vein thrombosis in her leg.
Okay, a DVT.
Right. The clot breaks off, travels to her lungs, causes a massive pulmonary embolism, and she dies 3 weeks after the initial fall. Is that a natural death that a ward doctor can certify, or is it a coroner's case?
That is absolutely a coroner's case, and it's a scenario that frequently catches junior doctors out.
Because the pulmonary embolism is a natural process, right?
Yes. While a PE is a naturally occurring physiological process, the event that initiated the unbroken chain of events leading to death was trauma. The fall. If she had not fallen and fractured her hip, she would not have been immobilized, and she would not have developed the fatal clot. Because the initiating event was traumatic, it must be referred to the coroner.
That makes perfect sense when you break it down like that.
Yeah.
Once a death is referred, the coroner's mandate is remarkably strict, isn't it? The inquest is not a wide-ranging inquiry into everything that went wrong.
No, not at all. The coroner is legally obligated to answer 4 and only 4 specific questions: who the deceased was, and how, when, and where they came by their death.
That's it. Who, how, when, and where.
That's it. The inquest is an inquisitorial process, not an adversarial one. It's a fact-finding mission, not a trial. The coroner's court gathers evidence to answer those 4 questions.
This is a critical distinction for medical professionals giving evidence. The coroner's court cannot determine criminal or civil liability.
Exactly.
A coroner might return a conclusion of unlawful killing, but they cannot name a murderer. They cannot rule that a specific surgeon was negligent. They simply establish the facts of the death.
And this requires immense discipline from the clinicians interacting with this system. There is a profound difference between establishing a medical cause of death and reaching a legal conclusion.
Can you give an example of that difference?
Sure. A forensic pathologist might conduct an autopsy and determine that the medical cause of death is exsanguination due to a stab wound to the femoral artery. That is a medical anatomical fact.
Right.
But the coroner's conclusion of how that happened, whether it was an accident where the person fell on a piece of glass, an unlawful killing during an assault, or a suicide, that is a legal determination based on the totality of the evidence, including police reports, witness statements, and the pathology.
The text notes that coroners have several short-form conclusions available to them, such as accident, alcohol or drug-related, industrial disease, lawful killing, unlawful killing, natural causes, or suicide.
Yes, those are the standard short-form conclusions.
But it also highlights a growing trend towards something called a narrative conclusion. Why is that becoming more common?
Because modern medicine has made death incredibly complex. 50 years ago, patients died relatively quickly from acute events. Today, we have advanced life support, prolonged ICU stays, and complex multi-system failures.
So simple label doesn't really fit anymore.
Exactly. If a patient dies following a complicated cascade of surgical complications intertwined with severe underlying natural disease, a short-form conclusion like accident or natural causes feels inadequate and often inaccurate. It doesn't capture the medical reality.
So what does a narrative conclusion look like?
A narrative conclusion allows the coroner to write a factual paragraph-length record of the precise circumstances of the death, providing clarity for the family and for any subsequent clinical reviews.
In order for the coroner to accurately answer those 4 critical questions, who, how, when, and where, and decide in a conclusion, they often need objective medical evidence.
Yes.
And that usually requires the ultimate investigative tool, the autopsy. This is where we need to clearly differentiate between the 2 types of autopsies, the clinical autopsy and the medico-legal autopsy.
For a medical student, understanding the difference in authority and purpose between these 2 is vital. The distinction is foundational.
Let's start with the clinical autopsy.
A clinical autopsy is hospital-driven. It's performed after a patient dies of natural causes, and its primary purpose is educational or diagnostic.
Like checking if a treatment worked.
Yes, perhaps the treating physicians want to understand exactly why a specific chemotherapy regimen failed, or they want to clarify a complex, rare disease process for research purposes.
And what's the most important feature legally?
The absolute most important feature of a clinical autopsy is that it requires the informed consent of the deceased's next of kin. Without family consent, it cannot proceed.
The text notes that clinical autopsies have been in steep decline globally for several decades. Why is that?
Largely due to advancements in antemortem diagnostics. With high-resolution MRI, CT scans, and advanced molecular pathology, we often have a very clear picture of the disease process before the patient dies. There's just less clinical mystery left to solve in the mortuary.
But the medico-legal autopsy operates under an entirely different framework.
It does. It's ordered by the state, specifically by the coroner or an equivalent legal authority. Because it's a legal investigation into an unnatural or suspicious death, it does not require family consent.
Not at all.
The family can raise objections, particularly for religious reasons, and the coroner will certainly consider them. But ultimately, the state's duty to investigate a potentially unlawful death supersedes those objections.
The aims of the medico-legal autopsy are also much broader and far more investigative than a clinical one. The forensic pathologist isn't just looking for disease, they're trying to reconstruct an event.
Exactly. The primary aims are to establish identity, estimate the time of death, and carefully identify and document all injuries.
And then interpret them.
Yes. They must interpret the significance of those injuries. Did this fractured skull cause death, or was it a survivable injury? They must identify any natural disease present and, crucially, interpret how that natural disease may have contributed to death.
What about toxicology?
They must look for poisons or drugs and assess any medical or surgical treatment the person received prior to dying.
What's fascinating about this process is how it maps directly onto standard clinical medicine. In a hospital clinic, you start by taking a patient history. In forensic medicine, your history is the circumstances of the death provided by the police and the scene investigators.
It's the same scientific method. In a clinic, you perform a physical examination. In forensics, you perform an external and internal post-mortem examination.
Based on that, you form a provisional diagnosis.
Right. You then order investigations, which in a hospital might be blood tests or a biopsy, and in forensics means toxicology and histology. Finally, you assimilate all that data to refine your diagnosis and produce a final report. It is the exact same rigorous process, just applied in a different setting.
Let's walk through the physical process of the autopsy itself, because it is highly regimented. It usually begins with the external examination, which we'll discuss more when we talk about trace evidence, but the internal examination is what most people picture. The standard approach involves a primary incision. Typically, this is a straight incision from the larynx or suprasternal notch down the midline to the pubis.
Usually, yes, but there are important variations. In cases where neck pathology is suspected, such as a hanging or manual strangulation, the pathologist will often use a Y incision.
How does that differ?
This involves incisions starting behind each ear, coming down to meet at the sternal notch, and then continuing down the midline. The Y incision allows the pathologist to reflect the skin of the neck upwards, exposing the delicate strap muscles, the thyroid cartilage, and the hyoid bone in a completely bloodless field before the chest cavity is opened.
Ah, so it keeps the neck pristine for examination.
Exactly. It's essential for identifying those deep, subtle hemorrhages we discussed earlier.
Once the initial incision is made, the next step is evisceration, the removal of the internal organs. The anterior abdominal wall is opened, and the rib cage is cut to remove the chest plate, exposing the heart and lungs.
There are a few different techniques for evisceration. The Virchow method involves removing organs one by one, but many forensic pathologists prefer variations of the Rokitansky method, which involves removing the organs en bloc, meaning all together as one interconnected unit, from the tongue down to the pelvic organs.
Why do it that way?
This preserves the anatomical relationships between the organs. If there's a stab wound that penetrates the stomach and goes into the liver, removing them en bloc allows you to trace the exact trajectory of the blade before you separate the tissues.
That's incredibly logical. Now, removing the brain requires a different approach entirely.
Yes, an incision is made across the scalp, usually from behind one ear over the crown of the head to the other ear, often called a coronal incision. The scalp is reflected forward over the face and backward over the occiput.
And then the skull is opened.
Right. The skull vault is carefully sawn open. The pathologist must be incredibly precise here to avoid tearing the dura mater, which is the tough membrane surrounding the brain. They want to inspect the epidural and subdural spaces for hemorrhage before the brain itself is extracted.
The text places a very heavy emphasis on the specific sequence of organ dissection once they were removed. It recommends a rigid order, especially for trainees.
It does.
Starting at the tongue, moving to the carotid arteries, esophagus, larynx, trachea, thyroid, lungs, heart, stomach, intestines, liver, spleen, kidneys, and moving all the way down to the pelvic organs, and finally the brain. Why such a rigid, unvarying order?
Because the autopsy is an inherently destructive process. Once you dissect an organ, you cannot put it back together to re-examine it in its original state. The rigid sequence ensures that absolutely nothing is omitted.
Even if the cause of death is obvious.
Especially then, if you open a body and see a massive, catastrophic rupture of the aorta, it is very tempting to say, well, there's the cause of death, and skip the rest of the examination. But in forensic medicine, the negative finding is just as important as the positive finding.
What do you mean by the philosophy of the negative finding?
It means that documenting the absence of disease or injury is legally crucial. If the deceased was involved in a car accident and suffered that ruptured aorta, but they also had a completely undiagnosed massive brain tumor, the legal context changes entirely.
Oh, I see.
Did the trauma cause the crash? Or did a seizure caused by the tumor cause them to lose control of the vehicle? If you don't examine the brain because you stopped at the aorta, you have failed the investigation. The rigid checklist protects the pathologist against complacency.
It makes me think of an airline pilot going through a pre-flight checklist. Even if they've flown that exact plane thousands of times, they touch every switch in the exact same order. The routine protects them against the chaos of this situation.
That's a great analogy. The autopsy is fundamentally an exercise in differentiation. Is this hemorrhage due to blunt force trauma, or is it a post-mortem artifact known as lividity?
Let's define lividity quickly for the listener.
Lividity, or livor mortis, is the settling of blood in the dependent areas of the body due to gravity after the heart stops beating.
So it sinks to the lowest point.
Yes. If a person dies lying on their back, the blood pools in their back, creating a purplish discoloration. It can look remarkably like a massive bruise to an untrained eye.
How does a pathologist tell the difference?
The pathologist must differentiate between the two. Bruising is blood that has escaped into the surrounding tissue due to trauma while the person was alive. Lividity is just blood sitting passively in the vessels. A simple incision into the skin will tell the pathologist which it is. That differentiation is the core of the work.
We could also acknowledge that the autopsy process is evolving. While the invasive internal examination remains the gold standard, there is a push toward minimally invasive options where appropriate.
Yes, the use of vertopsy or post-mortem computed tomography PMCT is becoming increasingly common. It's an incredible tool.
How is it used?
A full-body CT scan can visualize skeletal trauma in 3 dimensions without opening the body. It's exceptional for locating retained bullet fragments or identifying the tiny healing rib fractures in an infant that might indicate a history of physical abuse.
Is it replacing the physical autopsy?
In the UK, a PMCT is now a mandatory part of the protocol for investigating suspicious child deaths. It supplements the physical autopsy, but it rarely replaces it entirely in complex forensic cases.
But what happens when the practitioner deviates from that rigid checklist we talked about? What happens when the human element fails and objectivity is lost?
That's where things go wrong.
This brings us to a crucial part of the text discussing professional discipline and the pitfalls of the profession. The text introduces Moritz's classic mistakes and Petty's devil's dozen misconceptions.
These are essentially the cautionary tales that every forensic practitioner must internalize to protect the integrity of their work.
Let's look at Moritz's classic mistakes.
The first, and arguably the most damaging, is not examining the body at the scene when required. If you only see the body on a steel table under fluorescent lights, you have lost the entire spatial context of the death.
That makes sense. What's another mistake?
Another major mistake is misinterpreting post-mortem changes. We mentioned lividity looking like bruising. Putrefaction, the breakdown of tissue by bacteria, can cause skin blistering that looks like burn injuries.
Oh, wow.
And insect activity, like maggots feeding on the skin, can create defects that mimic chemical burns or even abrasions. If you confuse natural decomposition with trauma, you send the police down a false trail.
Another mistake on the list is performing an incomplete autopsy, which we touched on with the brain tumor example. You must examine everything, regardless of how obvious the cause of death appears.
Right.
And Petty's devil's dozen highlights cognitive traps. One massive misconception is assuming the autopsy always yields a cause of death.
This is a difficult reality for families and investigators to accept. Sometimes, despite a flawless, meticulous examination, the cause of death remains unascertained.
Why is that?
Certain toxicological agents leave no anatomical trace. Certain cardiac conduction abnormalities, electrical misfires in the heart that cause sudden death, cannot be seen under a microscope because the heart muscle itself is structurally normal. A pathologist must have the professional humility to say, "I do not know," rather than forcing a conclusion that isn't supported by the evidence.
Another dangerous misconception listed is believing that embalming won't obscure trauma. Can you explain why embalming is such a problem for forensic pathology?
Embalming is a chemical process used by funeral homes to temporarily preserve the body for viewing. It involves pumping formalin and other fixatives into the arterial system.
And what does that do to the tissues?
Formalin works by cross-linking proteins, which essentially cooks the tissue chemically. It makes the organs hard, rubbery, and totally changes their color, turning everything a uniform gray-brown.
So if there was a subtle injury,
Exactly. Say an emergency room doctor misses a subtle injury on a patient, like a small area of hypoxia in the heart muscle. The patient dies, is signed out as natural, goes to a funeral home, and is embalmed. Later, the family raises concerns, and the coroner orders an autopsy.
the evidence is gone.
The pathologist is now looking at tissue that has been chemically altered. Subtle bruising, early signs of infarction, delicate petechiae, they can all be completely obliterated by the embalming fluid. It destroys the evidence.
To truly understand the devastating real-world consequences of these mistakes, the text anchors this section by discussing the gouge inquiry. What exactly happened to prompt this massive public inquiry?
The gouge inquiry took place in Ontario, Canada, and it fundamentally changed the landscape of pediatric forensic pathology. It was launched following the discovery that a specific forensic pathologist had made systemic, profound errors in his autopsies over many years, primarily involving the deaths of infants and children.
What kind of errors?
He had misinterpreted post-mortem artifacts as evidence of trauma, he provided testimony outside his area of expertise, and he routinely jumped to conclusions of abuse without scientific justification.
That's horrifying.
It led to several parents being wrongfully convicted of murdering their own children. They spent years in prison based on flawed pathological evidence. The Honorable Stephen Gouge led the inquiry to figure out how the system had failed so completely.
The core tenet that emerged from that inquiry is a mantra that every pathologist is now taught. Think truth, rather than think dirty. What does that mean in practice?
It addresses the profound danger of cognitive bias, specifically confirmation bias. Imagine a police detective attends an autopsy. They are exhausted, they've been working the case for 3 days, and they tell the pathologist, "We are certain the husband beat her to death. Look for defensive wounds."
If the pathologist adopts a think dirty mindset,
They subconsciously interpret every ambiguous finding through the lens of a beating. A patch of livor mortis becomes a bruise. A post-mortem skin slip becomes an abrasion. They seek out evidence to confirm the police theory.
so think truth is the antidote.
Think truth demands absolute neutrality. You approach the body as a blank slate. You do not assume a crime has occurred. You let the tissue, the cells, and the chemistry speak for themselves, regardless of what the police theory is.
The inquiry also demanded strict independence. The pathologist's loyalty is not to the prosecution or the police, it is entirely to the scientific method and the court.
Yes.
And transparency is vital. An autopsy report must be independently reviewable. If I'm a defense expert, I should be able to take your written report, look at your photographs and histology slides, and understand exactly how you reached your conclusion. If your reasoning isn't transparent, it isn't science.
And this requires using unambiguous language. Pathologists love medical jargon, but ultimately, the report will be read by a jury of laypeople. If you describe a wound using obscure anatomical terms without translating what it means functionally, you fail the legal process.
To prove that poor discipline isn't just a historical problem, the text cites the NCEPO report. NCEPO stands for the National Confidential Inquiry into Patient Outcome and Death. They conducted a massive review of coroners' autopsies in the UK in 2006. The findings were, frankly, alarming.
They were deeply concerning. The report found that 1 in 4 autopsy reports were categorized as poor or unacceptable.
1 in 4, that's huge.
In a third of the mortuaries surveyed, anatomical pathology technicians were eviscerating bodies, opening the chest and removing organs before the pathologist had even performed the external examination.
And the brains were not examined in 1 in 7 cases. The presence or absence of injuries was poorly recorded.
Yes, systemic failures.
Why is a technician opening the body before the external exam such a catastrophic error?
Because the external surface of the body is a fragile crime scene. Imagine a victim who died of a fatal heroin overdose, but there's no obvious history of drug use. The only evidence might be a tiny, fresh needle puncture mark hidden between the toes or in the groin.
Right.
If a technician strips the body, washes it, makes the massive Y incision, and begins sawing through the ribs, Blood and fluid are going to cover the external skin. That tiny puncture mark will be washed away or obscured by the trauma of the autopsy itself. The external exam must be pristine.
This report showed a systemic failure of discipline, which is why standardized protocols and stringent quality controls were implemented globally to ensure methodological rigor.
Exactly.
Which perfectly transitions us to the idea that rigor doesn't just apply to the mortuary. It applies to the very beginning of the investigation. The autopsy doesn't start on the steel table. It starts where the body is found. The text introduces the United Nations Minnesota Protocol as the gold standard for scene investigation.
The Minnesota Protocol is a vital international document. It was originally drafted to guide the investigation of potentially unlawful deaths involving state agents, for instance, deaths in police custody, executions, or situations where the state failed to protect an individual.
But its principles represent best practice for any suspicious death investigation.
Right. The core directive is that the medico-legal death investigation begins at the locus, the scene.
The protocol dictates that if a death is suspicious, the forensic pathologist should attend the scene before the body is moved. I imagine this is rare in routine cases, but critical in complex homicides. Why does the pathologist need to be there? Isn't that what crime scene investigators are for?
Crime scene investigators are experts in collecting evidence, but they are not medical doctors. The pathologist needs to understand the environment to interpret the physiology.
Give me an example of what they're looking for.
What is the ambient temperature of the room? That affects the rate of body cooling, which impacts the estimation of time of death. How is the blood pooling around the body? Does the blood pattern align with the injuries, or does it suggest the body was moved after the bleeding stopped?
What about the weapon?
Is there a specific weapon nearby, and do the dimensions of that weapon match the wounds on the body? Seeing the body in situ gives the pathologist a spatial and environmental understanding that photographs simply cannot replicate.
And the scene protocols detailed in the text are incredibly meticulous. There is rigorous photography required. You don't just snap a wide shot of the room. Every photograph of an injury or a piece of evidence must include a macroscopic scale for size reference, and it must include an anatomical reference point.
Yes, a close-up of a bruise is useless if you can't tell if it's on a thigh or a shoulder.
Identity must also be confirmed formally, either visually by a relative, or if the remains are compromised, via fingerprints, dental records, or DNA.
But perhaps the most crucial directive regarding the preservation of evidence is how the body is handled. The text explicitly states that the body must be examined initially with its clothing intact.
This is a point that requires some clinical expansion. If the goal is to examine the wounds on the skin, why spend time examining the closed body?
Because the clothing is the first layer of defense, and it holds the geometry of the attack. External documentation is often far more valuable than internal dissection in reconstructing the sequence of events.
How so?
Let's take a stab wound to the abdomen. The pathologist must carefully match the cut in the fabric of the shirt to the wound on the skin. Does the trajectory align perfectly? If there is a single stab wound to the chest, but 3 separate cuts in the fabric of the shirt over that wound, what does that tell you?
It would suggest the fabric was folded or bunched up during a struggle before the blade penetrated.
Exactly. Or consider a gunshot wound. The clothing acts as a filter. If a gun is fired at close range, the unburned gunpowder and soot, which we call stippling, will deposit on the clothing, not the skin beneath.
So if the paramedics cut the shirt off?
If they cut the shirt off and throw it in the corner, and the pathologist only examines the naked body, they might conclude it was a distant gunshot wound because they don't see stippling on the skin. They misinterpret the range of fire because they ignored the clothing.
Wow.
Once the clothing is meticulously examined and photographed, it must be removed carefully, sealed in tamper-evident paper bags, not plastic, which causes mold and detained in a strict chain of custody.
The collection of trace evidence is also painstakingly detailed. The investigators are looking for the microscopic transfer of material based on Locard's exchange principle, the idea that every contact leaves a trace. They're looking for fibers, paint flakes, glass shards, and biological samples.
And there is a specific protocol for who collects what to avoid contamination. Crime scene investigators might take tape lifts from the outermost layer of clothing to capture loose hairs or fibers, but the pathologist takes the samples directly from the body.
Like fingernail clippings.
Yes. They will take fingernail clippings, looking for the attacker's skin cells or DNA trapped underneath from a defensive struggle. They will take head and pubic hair samples to compare against unknown hairs found at the scene. In cases of suspected sexual assault, they will take intimate swabs from the mouth, genitals, and rectum before the body is washed.
We also need to discuss the internal sampling protocols, because this is an area where physiology directly impacts forensic accuracy. When a pathologist needs to draw blood for toxicology testing, check for alcohol, drugs, or poisons, they cannot just draw it from anywhere in the body.
They absolutely cannot.
The text emphasizes that blood must be taken from a peripheral site, specifically a large limb vein, preferably the femoral vein in the leg. You actively avoid taking blood from the heart. Walk me through the physiology of why heart blood is unreliable.
It comes down to a physiological phenomenon called post-mortem redistribution. When a person takes a drug, say a tricyclic antidepressant, that drug is distributed throughout the body while they are alive. Many drugs are highly lipophilic, meaning they love fat, and they concentrate heavily in solid organ-rich tissues like the liver or the lungs.
So the concentration in the liver might be significantly higher than the concentration in the circulating blood.
Precisely. While they are alive, the drug is locked away in the liver cells. But when the person dies, cellular respiration stops. The cells begin to break down in a process called autolysis.
So they rupture.
Yes. As the cell membranes in the liver degrade, the massive concentration of the drug stored inside leaks out. Because the liver sits directly adjacent to the inferior vena cava and the right atrium of the heart, that drug seeps directly into the blood pooled in the central chest cavity.
It's basically contaminating the local blood supply.
Exactly. This artificially inflates the drug concentration in the heart blood. If a toxicologist tests that heart blood, they might see a massive level of the antidepressant and conclude the person died of a fatal intentional overdose. But it's an artifact.
And taking blood from the femoral vein prevents this.
Yes. The femoral vein is located far away from those solid organs. The blood sitting in the leg is much less susceptible to this central leaching effect. Femoral blood gives a much more accurate reflection of the drug concentration that was actually circulating in the person's brain at the moment of death. It is the gold standard for post-mortem toxicology.
What about urine?
Similarly, if you need urine for toxicology, you don't just scoop it out of the pelvis if the bladder is open. You draw it directly through the dome or fundus of the intact bladder using a sterile needle and syringe to ensure it isn't contaminated by abdominal fluids or bacteria.
Usually, this entire forensic process is linear. You start at the crime scene, move to the mortuary, send samples to the laboratory, and present the findings in the courtroom. But sometimes, the investigation requires going backward. And that brings us to our final major topic, exhumation. Reevaluating the physical evidence months or even years after the body has been buried.
Exhumations are exceedingly rare events. In the UK, you cannot simply dig up a grave. It is heavily regulated and requires a specific license from the Ministry of Justice.
Or a faculty from the Church of England, if it's consecrated ground.
Right. Some exhumations are for practical or personal reasons, like a family relocating remains to a new cemetery or large-scale cemetery development projects.
But forensically?
Forensically, they usually occur because of complex legal or insurance disputes, or because entirely new evidence of foul play comes to light after the burial. The text notes that they tend to be slightly more common in jurisdictions with lower routine autopsy rates, where a sudden medical question arises that was never investigated at the time of death.
The logistics of a forensic exhumation are massively complex. It is a multi-professional operation involving the coroner, police, cemetery staff, and very often forensic anthropologists or archaeologists to ensure the remains are located accurately and recovered respectfully and intact.
And the condition of the body the pathologist will face is highly variable depending on the environment.
How so?
The environment dictates the preservation. If the body was buried in a dry, sandy environment, the pathologist might be dealing with mummification, where the tissues have dehydrated and turned leathery. If it is an older grave, they might be dealing with complete skeletonization. If the grave is in damp, anaerobic soil, they might encounter adipose hair.
Let's define adipose hair for the listeners.
Adipose hair is sometimes called grave wax. It is the result of a chemical process called saponification. In a damp, oxygen-poor environment, anaerobic bacteria hydrolyze the body's subcutaneous fat, converting it into a firm, grayish-white, waxy substance.
Does that destroy the evidence?
Actually, no. Adipose hair acts as a preservative. It can maintain the shape of organs or even the imprint of injuries long after normal soft tissue would have decomposed.
Despite the state of preservation, the procedure for the exhumation autopsy itself is essentially identical to a standard forensic autopsy. You follow the same rigid steps, adapting for the condition of the remains. But there is one critical mandatory addition to the protocol, particularly when the exhumation is ordered due to suspected poisoning.
Yes, the soil samples.
The pathologist must take control samples of the surrounding soil. They take soil from above the coffin, below the coffin, and from all sides, as well as collecting any water or fluid pooled inside the coffin itself.
This step is the ultimate expression of forensic rigor and anticipating counterarguments. Let's use a classic hypothetical. Suppose a body is exhumed 5 years after burial because police receive a tip that the deceased's spouse poisoned them with arsenic.
Okay.
The pathologist tests the exhumed bone and hair and finds lethal levels of heavy metals. If they go to court with just that evidence, a competent defense attorney will destroy their case.
How so?
The defense will argue environmental contamination. They will say, my client didn't poison anyone. This historic cemetery is located next to an old industrial site. The soil is naturally saturated with arsenic. Over the last 5 years, the groundwater leached through the wooden coffin and deposited the arsenic into the corpse.
Wow, that's a plausible defense.
Exactly. By testing the soil controls from every side of the coffin, the pathologist can scientifically prove or disprove that theory. If the soil has 0 arsenic but the bone is loaded with it, the poison came from inside the body prior to burial. You are neutralizing the defense's argument years after the fact by being methodically rigorous at the gravesite.
That is an incredible example of how clinical knowledge intersects with legal strategy. It really highlights the central theme of this whole discussion: the objective, methodical preservation of evidence. From understanding the demographic data of violence in society, navigating the legal framework of the coroner's court, performing the meticulous, stepwise physical steps of the autopsy, right down to testing the dirt around a coffin. Every single layer is about stripping away assumptions to uncover the physical truth.
That is the absolute essence of forensic medicine. It demands scientific rigor and emotional steadiness. The forensic practitioner must remain completely calm amid the trauma, allowing the physical evidence to speak without embellishment or bias.
Well, as we wrap up this session, I want to leave you with a final provocative thought to mull over. Throughout Chapter 4, we focus heavily on the physical chain of custody: the clothing, the trace evidence, the physical pathology on the tissue. But we are moving rapidly into an era where our lives are inextricably linked to biometric technology. Smartwatches track our heart rate continuously. Modern pacemakers record physiological data, detecting arrhythmias at exact timestamps.
That's true.
As this technology becomes ubiquitous, will the digital autopsy, downloading the precise electrical activity of a victim's heart at the exact moment of a violent assault, eventually outpace the physical scalpel in establishing the when and the how of violent death? The physical body will always tell a story, but the digital shadow it leaves behind is becoming just as indelible, and forensic pathology will have to adapt to read both.
That is a highly compelling frontier for the field to grapple with. But before you go and ponder the digital future of forensics, let's make sure we lock in the foundational knowledge from today's text.
Good, yeah.
Here are 5 rapid-fire single best answer prompts based on the material we've just covered. I will read the question, pause briefly, and then reveal the answer.
Let's do it.
Prompt 1. Globally, which mechanism of homicide is proportionately much higher in female victims killed by an intimate partner compared to other female homicide victims?
Take a second to think.
Answer. Strangulation or asphyxiation, 27% versus 16%. If you need to review the specific mechanics of this, revisit the sections discussing intimate partner violence and the anatomical signs like petechial hemorrhages.
Next one.
Prompt 2. Under the coroner's investigative framework, what specific details is the inquest legally restricted from determining?
Think about the 4 questions.
Answer. Criminal or civil blame. The inquest is an inquisitorial process that only answers who the deceased was and how, when, and where they died. It cannot name a murderer or establish negligence.
Very important distinction. Number 3.
Prompt 3. According to the Gouge Inquiry into Pediatric Forensic Pathology, what cognitive bias must pathologists actively guard against by adopting the mantra, think truth, not think dirty?
Remember the detective example?
Answer. Confirmation bias. The danger of seeking out or interpreting ambiguous evidence merely to support a preconceived theory provided by police investigators.
All right, number 4.
Prompt 4. When drawing post-mortem blood samples for toxicology testing, which anatomical site is the preferred gold standard to avoid the artifact of post-mortem redistribution?
Think about the liver.
Answer. A large peripheral limb vein, preferably the femoral vein. You must avoid drawing blood from the heart, as drugs can leach out from solid organs like the liver after death, artificially inflating central concentrations.
Last one.
Prompt 5. If a forensic investigation requires an exhumation to test for suspected heavy metal poisoning, what crucial ancillary samples must be taken at the gravesite to withstand legal scrutiny?
The arsenic example.
Answer. Control samples of the soil from above, below, and beside the coffin, plus any fluid pooled inside. This is essential to rule out environmental contamination of the remains by the surrounding groundwater.
Excellent work. I strongly encourage you to read Chapter 4 of Simpson's Forensic Medicine alongside the conceptual framework we have built here today to really solidify your understanding and prepare for your exams or clinical practice.
Yeah.
Thank you for joining us for this deep dive.
Yes, thank you. Stay curious, stay objective.
We will catch you on the next one.